We have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health.
Imagica team ready to go?
Let me just give you count. Yes, ma'am. Now it's 3, 2, 1. So we are live with the attendees. Over to you, ma'am.
Good evening to all. I am Dr. Komal Mandgaonkar from medical team JB Pharma. Welcome you all for today's Lead HF webinar series, the virtual session 6. Lead HF is an academic initiative by JB Pharma where we monthly gives recent updates in the field of heart failure and cardiology. It's a privilege that today we have all the national cardiology experts with us who are going to share their expert insights on the sessions presented in the recently held ESC Congress 2024 in London. So to begin with the agenda of today's meeting, first there is an introduction and context setting by our moderator, Dr. Dilip Kumar sir, followed by there is an expert talk by Dr. Kaushal Pandey sir on the Best of ESC Congress 2024, What's New in HF, and followed by the expert panel discussion. It's a privilege to introduce our today's faculty, our esteemed moderator. We have Dr. Dilip Kumar sir, a senior consultant interventional cardiologist and electrophysiologist, Chief Academic Coordinator at Medica Super Specialty Hospital, Kolkata. Our esteemed speaker, we have Dr. Kaushal Pandey sir. Sir is a very senior cardiovascular thoracic surgeon from Mumbai. Welcome, sir. Our expert panelist for today's meeting, we have Dr. Nishan Taggi sir, is a Senior Consultant Cardiologist, Max Super Specialty Hospital, Delhi. Dr. Pankaj Jariwala sir, Senior Interventional Cardiologist from Yashoda Hospital, Hyderabad. Dr. K. Kalyanaraman sir, a Senior Consultant Interventional Cardiologist, Kalyanan Specialty Hospital, Kudalur. So welcome all the panelists, all the faculties. Now I request our today's esteemed moderator, Dr. Dilip Kumar sir, to please set the context for the meeting. Sir, please.
Thank you, Dr. Komal, and thanks to team JB Pharma for arranging this very exciting 1 hour of discussion on ESC 2024. So we all are aware that ESC is basically one of the largest cardiological conference in the world, and every year we see a lot of landmark trials. We have a lot of insights from ESC 2024 coming in, and which can change the practice guidelines, and we see many ESC guidelines being presented in the national annual ESC meetings. So this time the theme of the conference was personalized cardiovascular care, and we have seen some real good trials on drugs, devices, and some of the newer drugs, and then also some trials and registry data which tells us about the current scenario of treatment in heart failure. So without much ado, may I invite the speaker of today's evening, Dr. Kaushal Pandey, to present the landmark trials focus 2024, and then we will be discussing them one by one with our panel, esteemed panel members. So Dr. Kaushal.
Thank you very much.
Over to you.
Good evening. Can everybody see the first slide?
Yes, sir. Yes.
Okay. That means we are good to go. Anyway, at the outset, I would like to thank the organizers. I'm actually an odd man out in this jungle. I'm a cardiac surgeon, and all the rest of the panelists are esteemed cardiologists. However, my views are more likely to be surgically inclined, but that's very likely to add variety to the discussion. And obviously, I as a surgeon thinks quite differently when I look at a patient with any of these 4 topics broadly that we are going to discuss today evening. I do take personal interest in managing my own patients who have been heart failure, principally because a lot of our patients, when they come for surgery, they already have impaired heart function. To set the context, the commonest presentation of coronary artery disease in our country is actually myocardial infarction, And that's how most patients realize that they have got coronary artery disease. And then, of course, they go on to have multiple investigations. Then they go on to have angioplasty few times, sometimes even a dozen times. And by the time they reach us, a majority of them have impaired LV function. Impaired LV function has many definitions, but in our own practice, we call impaired LV function anything less than 0.35. I also am interested in MitraClip, and I actively assist my cardiology colleague whenever we are doing a MitraClip, because we do have a lot of patients surgical who eventually land up with device. And of course, all the other topics are of quite interest to me. So without further wasting any further time, let's get on to the topic as such. So I've been handed over a paper and which basically outlines 8 points which need to be covered today evening. The first one is, of course, current heart failure scenario, and of course, the role of guideline-directed medical therapy. So this was a beautiful paper, but I will just come down to the conclusion. So in this contempt, I'll just read out the headline, then make few comments. In this contemporary outpatient heart failure with reduced ejection fraction Italian registry, very high percentage, all the 4 patients, all the 4 pillars of heart failure were actually achieved in a majority of the patients, which is quite creditable. When we look at Indian scenario, it's quite the reverse. And I find very few patients actually on all 4 pillars. And of course, what are the strategies? What hasn't been mentioned here is how many percentage of patients actually reach full dose of ARNI, meaning 200 milligram twice a day. So this is a point which I would like my cardiology colleagues to answer, because I find moment you reach 200, your patients certainly look very different. So it's my goal and endeavor that at the cost of diuretics and other drugs which I will use in minimum quantity, I would rather have every patient on ARNI at 200. And believe me, at least 45 to 50% of my patients do attain 200 milligram twice a day. Now, can I have should we have the other participants to make comments on this so that we have one topic covered completely? Dr. Dilip, would you think?
Yeah. So we can discuss in just after trial which is presented. We can,
yeah. So before we go to the next topic, let's cover this.
It's a very pertinent point, I think, Dr. Kaushal, about the situation of heart failure medication and the penetration of all the 4 drugs with proper doses in Indian context is, what we see is around when it comes to ARNI, one of the registry data showed around 10% only. The patients who were destined to have these drugs, only 10% were having these drugs in proper doses. So we can ask the opinion of our panelist, Dr. Nishant. Are you there? Dr.
Yes, sir. Yes, sir.
Yeah, Dr. Nishant. So,
So,
what do you feel? How can we improve the situation in India? Like, how can we spread the awareness, and is there any genuine reason why we are not catching up? And still, you see, the scenario is not very rosy even in Western world. But in India, the situation is, really it needs a lot of intervention work. So, what's your opinion on that?
so I think with the proper education of physicians and these kind of seminars and CMEs, we have to spread this message that the guideline directed medical therapy, all 4 pillars should be started as soon as possible, and their dose should be adequately escalated every 2 weeks till they reach the target dose, because the mortality and the morbidity of the patient differs with different doses. Although we find it sometimes difficult when the blood pressure is in 90s, that is the main hindrance to increase the dosage of ARNI. And that's how most of our patients who are having dizziness or postural symptoms, postural dizziness, we are not able to increase the dose sometimes. But many patients over a period of time, sometimes over a period of 3 to 6 months, the blood pressure rises as the ejection fraction improves, and then you can further escalate the dose to 200 milligram twice.
Yes, I think we have a Trivandrum Heart Failure Registry. We have Medanta Heart Failure Registry, where we got some insights about the actual picture of heart failure medication in those patients who are coming to these tertiary care hospitals. And, also from of the kind of community experience, it's around 10 to 20% in tertiary care hospitals and less than 10 in general, practicing cardiologist. So we can move on to the next presentation, and that is very correct. I think 200 milligram twice daily. If we see among those patients who are getting ARNI, then maybe only 10% would be getting a 200 milligram twice daily. What we have seen the practice pattern in India. So I really got very kind of excited when you told that you keep your 50% of patients at 200 milligram twice daily. It's a very, very good sign. Yeah.
Simply because I'm quite convinced role of furosemide and other diuretics is very good only in the acute left ventricular failure management.
Yeah.
But in the long-term or chronic situation, I think there is virtually zero role for a furosemide type of drug, and dapagliflozin itself also acts like a small diuretic. So in my own practice, we don't use furosemide or any of such drugs in the long term.
Absolutely, and they can also be counterproductive. They can also cause renal dysfunction. So
Absolutely correct.
Dehydration can cause renal dysfunction. So
the other thing I would like to have comment before I close this chapter is frequently I have I've gone to bisoprolol from 5 BD to 2.5 BD, and even on a rare occasion 1.25 milligram twice a day, but got the ARNI to 200. Now I am not sure whether it's a good practice, but I am convinced my patients appear to be better when they are on a smaller dose of bisoprolol, but on full dose of ARNI. I would like to actually have one sentences from each of you because it will help all of us.
Yeah, Dr. Kalyan Raman, can you, give your inputs on Dr. Kaushal's idea of having ARNI full dose at the cost of a little lower dose of bisoprolol, obviously no diuretic like loop diuretics. Dr. Nishant, what I feel it's a correct practice, because bisoprolol in all the doses, it's not like the achieved dose they have shown benefit, but even at 2.5, 5 milligram, 7.5 milligram, 10 milligram, all across these doses, they have got benefit with a reduction in primary endpoints. So it's not a kind of not at all a bad idea. Rather, it's a good idea to keep ARNI at the highest dose, maximum tolerable dose, and keep bisoprolol around 2.55. That's a fairly good idea.
Thank you very much. If it is okay, can we move to the next topic?
Yeah, fine arts trial.
Okay. So next one is the fine arts trial, which is the role of finerenone in heart failure with very mildly impaired or preserved ejection fraction. I have zero experience because somehow at Hinduja and Lilavati, my cardiology colleagues also are not very fond of this drug for reasons which are not known to me. But this paper in conclusion clearly shows among patients with heart failure and a mildly reduced or preserved ejection fraction, finerenone reduced the risk of primary composite outcomes of cardiovascular death, total heart failure events, reduced total heart failure events, and improved overall health status. These findings were consistent across pre-specified subgroups, including across all LVF, and of course, those also on SGLT2 inhibitor. Hyperkalemia was more common, which is easily understandable. These data support the use of finerenone in patients with heart failure with mildly reduced or preserved ejection fraction. I admit that, I haven't used this drug. So I think I request all of you to contribute to discussion on this, and I'm sure I will benefit from your discussion on this topic.
Have we got Dr. Pankaj Jariwala on board? Dr. Komal?
No, sir. He has not yet joined. Dr. Kalyan Raman, sir, is here.
Dr. Kalyan
sir,
Raman, I think we can have your inputs and your ideas on finerenone in HFpEF, the fine arts trial, the message and the promise which it delivers.
Dr. Kalyan Raman, sir? Or Dr. Nishant Tyagi sir is there, sir. Meanwhile.
Dr. Tyagi, can you
Uh,
throw some light on this?
I have yet to use this drug. I haven't used it till now.
I can give some inputs. I have done a kind of we do some medical cardio talks every 1 or 2 months, and I picked up this kind of this topic, Fenrinon for cardiologists, and presented a 10 minutes talk on that. And this is indeed a very fantastic molecule. So this is a non-steroidal MRA, and it gives you lesser hyperkalemia than the existing drugs, and this is a larger molecule, so it binds the receptor whole soul, and it is more selective. And other side effects of non-steroidal MRAs, which are not there with this Fenrinon. And Fenrinon has got very good 2 trials, is Fidelio and Figaro, and that was also kind of a twin trial. So the primary endpoints of one trial, Fidelio, was the secondary endpoint of the other trial, and the secondary endpoint of one trial was the primary endpoint of one trial. So the primary endpoint in Fidelio was cardiovascular outcome mainly, and secondary was renal endpoints, and in Figaro it was just reverse. So what both the trials and the the cumulative data from Fidelity, the Figaro and Fidelio cumulative data was published in a Fidelity data, and the pool analysis showed a significant reduction in cardiovascular MACE rate, and also very significant reduction in worsening of renal dysfunction, and that was the p-value was highly significant, and this was across the patient with GFR between 25 to 90, or the patient had albuminuria. So diabetic kidney disease giving better cardiovascular outcome and a better renal outcome. So that was the idea, and a lot of nephrologists, our colleagues, they write Fenrinon in diabetic kidney disease. So with this MRAs coming and giving us more benefit, it was first time in fine arts it was evaluated for heart failure with preserved ejection fraction, where we have only one drug, that is SGLT2 inhibitors, which gives us a benefit, and that can modify the disease process. And thankfully, this is the second drug, in fact, which has given this hope that this can further reduce cardiovascular endpoints and adverse events and MACE rate. And if we get more and more data, then probably this will be the second drug after the SGLT2 inhibitors, Fenrinon, which can be included in HFpEF patients. So this is a very, very promising trial. Dr. Kalyan Raman, you were not there, so you can also give your idea about Fenrinon, in which cases you use, and what about fine arts trial, how kind of excited you are or happy you are with this results from fine arts.
Good evening, sir. We have not used any Fenrinon till now. Routinely we are using Eplirinon, ARNI and SGLT2 inhibitors. But because of the cost, we are not using Fenrinon. But definitely when the price comes down, we can use it in.
That looks very promising. Looks very promising.
Moderate and mild.
Yeah, the kind of trials which it had, basically it had 3 trials now.
Yeah.
Figaro, Fidelio, and then this is fine arts, and then maybe in future, I think you are very right. The logistic and the cost is one of the main factors behind this. Yeah. So we can move on with the third,
Okay.
trial.
Sure. So the next topic is on clinical insights on use of dapagliflozin across ejection fractions. It is, of course, in combination with the ARNI. So I'll just come down to the conclusion itself. In conclusion, this trial, in routine clinical practice, the initiation of ARNI and SGLT2 therapy led to significant improvements in the health status of heart failure with reduced ejection fraction patients and contributed to improved ejection fraction. Patients with heart failure with improved ejection fraction experienced a better quality of life at 1 year in comparison to the other group. Additionally, heart failure with improved ejection fraction was linked to better overall outcomes. So it is recommended that all heart failure patients undergo the Kansas City assessment because it is an independent predictor of patient outcomes. Yeah, so I think, of the four pillars, SGLT2 has definitely established its own place, which wasn't the case only 5-6 years ago. Only difficulty I find with this particular drug is majority of the female patients within a month or two, especially if they are above the age of 55, 60, do get recurrent urinary tract infection. And in my own practice, almost 50% of the female patients we discontinue the use of SGLT2 inhibitor. Surprisingly, some of the elderly men also experience higher incidence of urinary tract infection. So though I was very encouraged and enthused about this, but in the real world, I find almost dropout rate of at least 30 to 40% in men and above 50% in women. Now, so I'm a little disappointed, and that is why this is the last of the drugs that I add to the heart failure patient. Majority of my patients actually are not getting SGLT2 inhibitors unless they are very young. So I made these comments simply because we've got 4 experienced cardiologists here, whether they share similar views or how they handle this kind of a problem.
Yeah.
Yes, Dr. Dilip, I would like you also.
So we beg to differ on this particular aspect. We don't see that much of UTIs, and maybe the reason is we have got counselors for heart failure, and the patient is counseled about the hygiene and basically the genital hygiene is very important here.
Yeah.
And also previous history of UTI. So we screen the patients properly. We advise them, and then we have a counselor which tells us about the genital hygiene, and that's why our in our practice maybe the dropout rate is, I think, very negligible. I tell you, maybe it's a kind of outlier what you got. But if you counsel, I know you people are busy operating patients, but your juniors or your heart failure coordinators, if they can counsel the patient, the things can change. So Dr. Kalyan Raman and Dr. Nishant, what is your dropout rate of SGLT2 inhibitors in male and female patients?
In my practice, there is no actual dropout. Most of the patients, they follow ARNI and SGLT2. But some patients, we have to reduce the dose of ARNI because of the hypotension. Sometimes you have to reduce from 100 milligram to 50 milligram, or even half of 50 milligram. Most of the patients, they are followed and their EF improves. They're happy with the treatment, even though it is slightly costly.
But Nishant, about UTIs with SGLT2, what is your experience?
There are two kinds of things. One is the local fungal infection, which is dealt by keeping a proper hygiene. The other thing is recurrent UTI. I find mostly if there is an elderly male, there is something like BPH, which is causing residual urine, and that is causing UTI. And if that is taken care of, the chances of UTI again becomes negligible. In females, especially in heart failure, once you restrict the fluid intake, then it becomes a little difficult because fluids, as endocrinologists say, 3 liters should be given with SGLT2. But in heart failure patients, we usually recommend 1 to 1.5 liters. So that is an issue. But on a basis, when we follow up these heart failure patients, what I usually do is to follow them with a KFT and a urine routine microscope to see the pus cells in their urine. So if the pus cells are becoming more, we are alarmed just before the UTI is presented. So you can start SGLT2, and after 2 weeks, you can call with a urine routine microscopy, and that really helps. If the pus cells is 2 to 4 or less than 5, that means the patient is tolerating it very well.
Perfect, I think, yeah. So this study is also regarding those patients who improved on ARNI and SGLT2 inhibitors and how were their experience, and it shows those patients with heart failure with improved ejection fraction, they also had got better KCCQ score on these drugs.
Do you see any difference in the diabetic population versus non-diabetic as far as UTI is concerned?
Yeah, obviously, diabetic patients were more careful. and obviously the chances will be a little higher.
Yes. Okay. So if that is okay, should we go to the next topic?
We can go.
I'll just come to again the conclusion. The conclusion of this particular study is ARNI treatment resulted in significant reductions in NT-proBNP levels in heart failure patients under and over 80 years of age with comparable discontinuation rates. These findings highlight the effectiveness and safety of ARNI in the management of chronic heart failure in the elderly, offering very good, and of course the studies from Japan where the elderly population is very high. Our own experience is that the postural hypotension with ARNI is higher in patients above the age of 75, especially if you cross 100 milligram BD of ARNI. So we are careful that above the age of 75, we are very reluctant to try and touch 200, though that is our goal. I would now like to have comments on how do you handle postural hypotension in this elderly group of patients, which is quite specific for them.
So this study is from Japan. So Japan, where the longevity, the lifespan of people is around more than 90 years. And in India, it is 69 years. And the Indian patients, they become very frail when we reach their 80s. So this octogenarian population and how much relevant this is for our population, it's little kind of debatable. But of course, our 70s is their 80s as per the physical agility is concerned. So in 70s, if we go, so we have to start with the lowest dose, 25 milligram twice daily. I'd start there, and definitely I would not be very happy taking them altogether 200 twice daily. And we have to be careful about diuretics and postural hypertension, and we have to counsel patients to get up very slowly from the bed, and these all precautions should be given. So Dr. Nishant, what do you say, octogenarians and ARNI uses? How many of your patients are in 80s and taking ARNI?
Very few patients actually, but yeah, I have given it to one of the colleagues' doctor's father. He was taking till the age of 94 and was tolerating it very well. So it is very well tolerated. Just you have to look for more carefully to the electrolytes, blood pressure, and the KFT.
Yeah. So dropout rate is 12% in this trial, more than 80 years, and less than 80 years is 6%, 7%. So it becomes almost twofold. Dr. Kalyan Raman, how many of your patients of more than 80 years are there who are on ARNI?
I don't have any patients in that age group, particularly in ARNIs.
Because our life expectancy is less, so Indians, after 75, 80, the deal of living also becomes less. So I always tell patients that you see Donald Trump is 85 years, is contesting for presidency, so you also have more opportunity. So it's never to get disheartened and hopeless about the age.
It's interesting. Only 20 years ago or 25 years ago, I operated a 75-year-old and everybody was laughing at me that I offered CABG to a 75-year-old. And now, in Mumbai, to operate on 80 to 85 is actually become fairly common. But I think this has something to do with the socio-economic improvement in, at least in metros.
Yes.
So I offered surgery to 85-year-old. The family takes it for granted that it's a usual case and everything is routine. So I tell them that, look, though we are doing serum creatinine and carotid assessment, but a 80-year plus is a 80-year plus. But somehow the acceptance for surgery has actually risen very high in metros. And so for us to operate on 80 plus is actually become routine. And none of them seem to be frightened. I am frightened, but the family doesn't appear to be.
Yeah, no, I have one point here to make. So it's not about years. Okay, that is also another point. But what I see, in India, the patients who are diabetic, the proportion is higher. And
Yes.
comorbidity is higher. By the time they reach 80, 85, they get some renal compromised. So GFR becomes around 20, 22, 25, and something like that. And that is real concern for this polytherapy. And then irony also comes there and how to do. So that is the basic reason of your hesitation in adding those patients. But definitely those patients who are good require surgery. I did a pacemaker of a patient who reached 100 years. In 101st year, I did a pacemaker, and that was the news in Calcutta. So yes, our socioeconomic condition is changing, and maybe it's getting better day by day. So we can go to the next trial, sir.
Okay, fine. So the next one is on beta blocker continuation in post-MI patients.
There's a Helios trial. There was one more trial, sir, which we just missed. Helios is a new drug which is coming. Just one more trial, one more slide back, sir.
So just go back one slide.
Yeah, so this is a new drug which has come, vutrisiran. So we have now tafamidis in treatment of amyloidosis, those who are refractory heart failure. And this drug has shown some positive results. But these are very small number of patients, not large number of patients. So we can't be generalizing this at this moment. And these are very costly drugs. So maybe therapy cost would be something like 1 lakh per month. So that is the problem. And amyloid cardiomyopathy is also diagnosed very less often in India. And but this is a good thing that we are getting some drugs for these indications. Dr. Nishant, have you come across any patient with cardiac amyloidosis, TTR type?
So here in Gangaram, they are doing this study, and there's a doctor. He has given me his number, so he is following up this patient. There are only 24 patients, and to differentiate the type of amyloidosis, and they are giving this therapy. So they are doing it as a trial and asking for referral from all over Delhi, because these patients are very rare, and in years' time, you find 1 or 2 patients of amyloidosis. So one center I know.
The drug is given for free from the company, or they are buying?
They are giving it as a trial. All the investigations are free, and the drug is also.
Very good. So we can go to the next presentation.
Yeah, I just make one comment on the diagnosis of cardiac amyloidosis. Moment you have a interested cardiologist in amyloidosis of the heart, their diagnosis becomes very rampant. So we have a cardiologist whose radiologist turned into specifically into cardiac MRI at Jupiter Hospital in Mumbai. She has become really good at diagnosing. So they are diagnosing almost 3 cases a week in just one institution of cardiac amyloidosis. Whereas we at Hinduja don't seem to be picking it up because we're obviously missing the diagnosis.
Yeah.
So I think with more awakening, more understanding, and improvement in the radiologists of understanding of amyloid, this diagnosis will become very common.
So one of the very catchy point is your ECG and echo kind of if they're not matching. So ECG shows a low voltage complex and echo shows hypertrophic myocardium. So this is one catch. One should be getting alerted about this entity, and those patients with refractory heart failure. One study showed 15% of aortic stenosis patient, they are basically cardiac amyloidosis, and 28 to 30% of HFpEF patients might have cardiac amyloidosis. So you're very right in saying if we look for this, we get cardiac amyloidosis as well. Dr. Kalyan, what about in your hospital about amyloidosis awareness and picking up these patients?
We don't have, we are not received any patient from amyloidosis.
Okay. So if you are into diagnosing these patients only, then you can pick up. Otherwise, you will keep this patient on diuretics, and patient will do well, and all of a sudden cardiac arrhythmia can happen, and they can die.
Quite right. Quite right. Okay, so we will move forward.
Yes, sir.
So assessment of beta blocker interruption 1 year after uncomplicated myocardial infarction on safety and symptomatic events requiring hospitalization. I'll just come to the conclusion. This study did not demonstrate the safety of beta blocker interruption in MI patients with preserved LVEF that led to a higher rate of hospitalizations, especially in hypertensive patients. Beta blocker interruption did not improve patients' quality of life and increase blood pressure, systolic, diastolic control, and heart rate. Basically, I think this is a completely medical issue. I will request the cardiology friends to take over on this part of the subject.
Yes, I
Dr. Lilly?
request, sir,
Yes,
please.
So yeah, this is a strangely a few months back in PCR, we had a trial. It showed a registry data which showed beta blockers may not be giving us survival benefit and any positive effect in patients post MI if we continue for lifelong. And this is just a kind of a somersault on the result, aspect, where it shows if you stop beta blocker after 1 year, you are going to lose out patients and chances of adverse events will be higher. So, but the common practice is to use beta blockers, and that is being upheld in this trial again. So it's just a kind of a reaffirmation of our belief and faith in beta blockers and the initial studies which proved the benefit of these beta blockers in post-MI setup. Dr. Nishant, what is your take on beta blockers post-MI?
Yeah, so post-MI, we usually give beta blockers started to a maximum tolerable dose according to blood pressure, heart rate. And once the patient is stabilized on beta blockers, I think very rarely somebody stops it at a follow of 1 or 2 years. And actually, stopping it or withdrawing it becomes very difficult for the patient, sir. He will come with palpitation and high heart rate eventually. So once it is stabilized, the patient is stabilized on a particular dose, we usually don't touch that.
Yes. So the problem and the confusion started because in chronic heart failure patients, beta blocker has not proven benefit in its efficacy in more than 40% ejection fraction patients. But in post-MI patients, all subgroup, even there are more than 40, 50. So what is different in post-MI patients? Once the revascularization is done, one angioplasty is done, or say we have not done anything, even then 40%. So this chronic heart failure, and how come these post-MI patients become different? So there lies some confusion. Okay. More than 40%, what should be the fate of beta blocker? Okay, say if the patient has ischemic heart disease, MI, till 1 year we gave the patient to get benefit and remodeling. After 1 year, the patient looks like similar to chronic heart failure patients, isn't it? Then there is no relevance from the heart failure therapy HFrEF perspective. So there was the basically dispute, and this dispute still holds, and I really don't know. But post-MI ischemic substrate, beta blockers, always there is a kind of hint of benefit remains there.
Somehow I was always taught that once a patient gets stabilized on beta blocker, it's not meant to be stopped.
Yes.
So I am always reluctant to discontinue because I have a fear that should the patient have a myocardial reinfarction, then I have a lot to answer. So
there can also
if it is,
involved.
Yeah.
Dr. Kalyan can also give some input on this. Beta blockers post-MI patients with heart failure ejection fraction of more than 40%.
I don't stop beta blockers, particularly in patients even severe heart failure. Even if there is an indication to stop, I usually used to reduce gradually, not suddenly. We don't stop.
Correct.
Most of the patients are continuing the beta blockers.
So we practice in the same manner.
Yeah.
Yes.
Okay, so I will move on. We still have 15 minutes, but two major topics still left to be covered. So in the interest of time, we'll go to inclisiran and of course, LDL, which is the current hot topic. And so I'll just make a few comments as a surgeon. So for me, who is this high risk patient or a patient where I'll be very concerned about managing the LDL. So for me, these are patients where I have done a bypass surgery under the age of 40. So these are patients who are at a very high incremental risk of need for re-intervention, be it angioplasty or be it a redo coronary artery bypass surgery. Despite doing multiple arterial grafts on young patients, still 15-20 years later, there is always a need for re-intervention. Thankfully, because of advances in angioplasty, majority of the time it is angioplasty. But to do a re-operation in a patient with multiple arterial grafts is not very easy and obviously very difficult for the surgeon and of course for the patient. So for a patient of this kind, we are very aggressive, and I think inclisiran would be a very strong recommendation for that group of patients. The other group that we frequently encounter are patients with familial hyperlipidemia of all sorts, and again, this would be a wonderful drug for that. Still, it leaves us with some patients who are in the age group of 40 to 70, where despite rosuvastatin of up to 40 milligram, the LDL still remains above 100. So for me, these are the three broad classes of patients where I would use this kind of drug. And again, this is more a cardiology type of thing. So I would love to hear from the 3 or 4 people in our group right now. Yes, Dr. Dilip, please take over.
Yeah, so we like last 2 trials showed the feasibility of reducing LDL less than 30 and 20 even, and what's the kind of risk and benefit. So risk is almost nil. That is what we have come to a conclusion at this moment with all these trials showing that these are innocuous if we bring down LDL to even 15-10, and there was even incremental benefit which was seen in FOURIER trial. Now coming to Victorian Initiate, where we want the LDL to be knocked off very quickly after acute coronary syndrome. So I will also tell you a story of a lady who is admitted in my hospital waiting for corporate clearance. So the story of this lady was, she's just 39 years. Her husband works in corporate, and she developed MI 9 months back when she was in Bangalore. Then the primary angioplasty was done. 2 stents were put in, one LAD and one a circumflex. Then the patient came to me with another ACS event after 2 months of this event in Calcutta. So I checked the angiogram, the LAD circumflex stent was fine. The OM had a thrombotic occlusion. So I fixed that, and then I put this lady on inclisiran. And because she had recurrent event, twice she had acute coronary syndrome, she was on high dose of statin, 40 milligram rosuvastatin, and antiplatelets, of course, ticagrelor or aspirin. And her LDL was around 72. So I thought, let's bring the LDL to around 30-40 for her. And I started inclisiran. And after taking 2 days of inclisiran, after 3 months it took, and then I got a call from corporate. Dr. Kumar, please don't write this inclisiran. It is difficult for corporate to give the patient this much of costly drug, and you can avoid, then you start the other drugs and try it out. And so we skipped the next, or I think we were about to give, and she was not getting it. In meantime, she got admitted again 5 days back. We saw that the LAD, just prior to the LAD stent, there is a occlusion, which is 90%. And I'm really, confused what to do at this moment. And I'm again willing to restart inclisiran. Now my idea would be keeping LDL less than 20 in this patient. And I'm going for a drug-eluting balloon angioplasty on Monday, because and that is what we got the approval. So these kind of patients, Dr. Nishant and Dr. Kalyan, you would be getting as well. So what do you feel inclisiran to be initiated as early as possible in these recurrent events, like Dr. Pandey also, alluded to young patients with kind of recurrent events, multiple surgeries, multiple stents? Then would you wait for pempidoic acid or HTMI to work and bringing it less than 55, or you'd be straight away going for inclisiran with Victorian Initiate kind of strategy?
So, I also see a couple of patients with young patients with rampant atherosclerosis. Until now, we have the limitation of giving to maximum dose of statin. Bempedoic acid has come in last couple of years, hardly makes 10, 15, 20% decrease further. Ezetimibe 5 to 10% further. But still the LDL is high, and one patient who I have put on all three drugs and got a CT angiography done, calcium score is 1700 and LCX RC is 100%, LAD is 50%. So I've asked him to get permission for an angiogram and take permission for this. So this is kind of familial. Another advocate came yesterday. His father got a bypass surgery at 45. He is 45 now. Got a CT angio done, calcium score 1800 with a LAD of 90%. So I'm admitting it for angio. But these are the patients who have a family history at very young, a father having MI or a bypass surgery at the age of 40s, and again they are also facing the same trouble at the same age.
Correct.
So this is probably familial hypercholesterolemia and presenting it too early.
In UK, this is being pushed like anything, and they are, I think, trying to get it approved in preventive cardiology setup, where patients for primary prevention they will be given this inclisiran. So NHS can definitely afford it. Unlike in India, it's really difficult to afford. It's a costly drug, but this I think is very promising molecule, and in future it will be used more and more. Dr. Kalyan. Yeah, so your points on this.
Yeah, I had one patient of age 22 with single cell disease within PTCA, but his LDL is around 400 something. We give all statins, everything in a maximum dosage. Then even then LDL is around 250. We advised to start inclisiran, but the patient's affordability is an issue.
Yes.
Actually, can I add? I'm Dr. Pankaj Jariwala from Hyderabad.
Dr. Pankaj, when did you join? We missed you all along.
Yeah.
Yeah.
Oh, thank you, sir. Actually, I was busy in angioplasty, sir, just now.
Yeah.
Actually, the doctor, what he's telling, actually, there are two types of homozygous familial hypercholesterolemia. One is LDL receptor positive and one is receptor negative.
Mhm.
So, inclisiran will only work when there are LDL receptors are there. Because the mechanism of inclisiran is it prevents the degradation of the LDL receptor, and it tries to increase the LDL receptors on the surface. So then only this will work. Otherwise, it will not work actually. Another therapy is apheresis, plasma apheresis in such a familial hypercholesterolemia, where you can, but that you have to do, you need to have special filter and all. I think Dr. Iyengar in Bangalore, I heard that he does this kind of treatment in such kind of cases. So
It's like this dialysis, there is some changes they make, and then they could do it, plasmapheresis.
yeah,
The commonest one is LDL receptor, positive type, and majority of these cases it works. But it is pertinent to know whether this drug is going to work or not. But I have seen patients coming down, their LDL coming drastically down in 5 to 6 days even. If you start this drug, 10 days, 15 days, and LDL is, nowhere to be seen, very less. It's a very promising drug, and this is a Victorian initiate. They did not wait for other two drugs to act, and they started inclisiran, and maybe we see how the results will be in future. So we have 10 minutes left, and one interesting trial to be discussed. Pankaj is also on board, so I think that we can go ahead with the last.
Yeah, thank you very much. Yeah. Yeah.
So, sir, this is your topic. You can give some.
Yeah.
Like,
So yeah.
which
So-
patient you say refer for MitraClip, because it shows the second trial like COAPT, which shows benefit.
Yeah. So only problem with this is to find, somebody who can do a good job. But I'm quite convinced that all these elderly patients above the age of 70, moment you find that managing their heart failure is difficult and they have moderate to severe MR, while they are still in a preserved condition, that is the right time to offer MitraClip. And we've had experience with 5 patients, and all 5 really made a dramatic improvement. So we are quite gung-ho. The only problem, of course, is cost. And so initially the patients, but then, we explained to them that, look, each time the patient is getting admitted for management of heart failure, especially in the ICU setting, the costs are steep. And so if you add up those costs, MitraClip is justified. So we are very gung-ho. Yes, the limiting factor is only the cost. And today, thanks to advancement, doing a septal puncture and all those things have actually become quite standardized. So we are very happy with this procedure. Only cost is the constraint. I would like to hear from the other 4 people, cardiologists, what
Yeah,
experience they have.
I agree, sir. Actually, I have done 2 cases of MitraClip. One is around 89-year-old lady whose surgeon refused, and she was having completely flail posterior mitral leaflet, sudden rupture, and so we did it, and it was a torrential mitral regurgitation, and so there is some residual mild mitral regurgitation is still there, but now almost 8 to 9 months over, she's completely in NYHA class 1. And another patient post TAVR, patient is having severe mitral regurgitation. We thought that after TAVR, MR can come down because of the LV pressure comes down, but it did not come. I think it was organic mitral regurgitation, structural, and then we did it. So that patient also doing very well. So particularly elderly population where surgeon refuses, post bypass surgery where redo surgeries are not possible in such elderly population, it is very good therapy for the, of course the cost is very big, around 34 lakhs to the patient, but procedure is not that very great, challenging as TAVR. It is like something like we are doing all the balloon mitral valvuloplasty, so we have good experience of transseptal puncture, and transesophageal echo is the key while doing the procedure. 3-dimensional echo, those who can do, they do very well.
Yes. Yeah, Dr. Nishant and Dr. Kalyan, your take on this from this procedure. So Dr. Nishant.
So I haven't done this, and but yes, I am seeing patients who have undergone this and are doing well. A couple of patients. So it's a good treatment for those who are not operable. Obviously, the MR reduces and then patient definitely improves.
So my take on this MitraClip procedure is, after doing a lot of TAVRs and all, but I feel TAVR is more challenging.
Yes,
more,
yes.
it requires
I agree, sir. I agree.
more skill than anything, and the kind of BMVs which we have been doing for so long. This MitraClip procedures are very, very streamlined and quite safe procedures. You don't have very less chance of patients getting out of hand, and the puncture will be guided by transesophageal. Your entry into the LV is guided by again a T as well as 3DT, and then in 2 views we see bicommissural view and LVOT view. You see the orientation of clip and just deploy there. So it's not at all a very difficult procedure. The main problem of this procedure is cost, and I'm really hopeful when the MiClip will come, like MiVal, the Merrill is working on MiClip, and this is in the final stage of their investigation and kind of research, and it will be available soon in next couple of years, and then probably we think that it will be less than 20 lakhs and it will be more affordable. When TAVI was getting launched in maybe 2000, MiVal was getting launched in 2016 or 17. We went to WAPI, their center, and all from also USA, the stakeholders were there, Dr. Samin Sharma, Saibulkar and all. So we told them that please keep the cost of TAVI 10 lakhs at that time. So they did not, give us more importance at that time. They kept it around 16, 17 lakhs, but now it is less than 10 lakhs. Other valves are coming. probably this my clip will be within 20 lakhs, what I'm hearing about, and then things will really going to change. So this is my take
Yeah,
on.
already the enrollment has started, sir. Already
Yes,
the
yes, yes.
enrollment has started,
Yeah.
and
So in
our
Vedanta
center
we
is one of the
doing-
center for the. We are also doing that.
Yeah. Yeah. So once it comes in the commercial use, that will be really a game changer. And I remember in 2022 when I went to PCR and Steve was showing a case. This patient had atrial fibrillation, MR of moderate to severe. LA was very large. LA was around 48, 49. And then I asked, why are you not offering this patient kind of AF ablation fast? Why are you going for clip? If you do AF ablation, if AF gets reverted, this cardiomyopathy will be reversed. So there is a lot of off-label clipping happening in Western countries, I tell you. And here comes the role of choosing patients rightly. If we choose patients rightly, probably patients will be really benefited. So we are think right
There
at
are some
stage-
couple of patients are there, sir. There are some
Yeah.
couple of patients are there, like CKD subset of patient where you cannot give ARNI to them. So actually, with
Yes.
the availability of ARNI, many of the mitral regurgitations have subsided. Actually, my one patient was there who was having severe MR, and I gave him an option of this mitra clip, and he was ready. But I thought, let us give him optical medical therapy first. So I started him on all these GDMT, and within 3 months, his MR became mild actually.
No, the MR
But there
is
are
also
some subset
dynamic.
of patients.
MR is also
Sir.
dynamic and very volume sensitive. If the patient is
Yeah.
hypervolumic, the MR will be looking more. And once you make the patient euvolumic, even though ARNI may not be there, but the MR will reduce. And once ARNI works remotely, gets reversed, then it will further come down. So you are very right.
But there are some CKD patients are there, sir.
Yeah.
Despite of giving diuretics and all, their creatinine is something like 3, 4, and I am not able to give ARNI to them. And I have given drugs like isolazine and other beta blockers and all those things, but they're still in the mitral regurgitation. I
Yeah.
think this mitra clip will
These
be
are the
beneficial
organic
in such kind of cases.
These are organic MRs, and yeah, these are proper patients. So I think this 8 o'clock, Dr. Pandey,
Yeah.
it was amazing to, the trials you presented, and it was amazing talking to our panel. So over to Dr. Komal for concluding remarks, and it was a wonderful interaction, and we learned a lot together.
Thank you very much.
Thanks, sir. So on behalf of JB Pharma, I would like to thank all the expert faculties for such a wonderful insights and such a wonderful sessions. Thanks, Dr. Kaushal Pandey, sir, for such a wonderful
Thank you.
sessions. Thanks, Dr. Dilip, sir, for such a wonderful moderations. Thanks, Dr. Nishant Tyagi, Dr. Kalyan Raman, and Dr. Pankaj Jariwala, sir, for sharing your expert insights. Thank you, sir. Thanks a lot.
Thank you. Thank you.
Good night.
Good night, sir. Good night.
Good night.
Sir, absolute privilege to have all of you here with us on this program. And just to tell you that we are also going to host this program on our JB Next app. So another 10,000 plus doctors will see it, at their convenience, because there are a lot of young doctors are also on this platform.
Thank you.
Thanks,
Thank you,
sir.
sir.
Good night. Good night.
Good night.
Thank you, everyone. So now with the permission, can I end today's meeting?